Good evening. We are moving on to the last session of today's program, and this is going to be even more interesting and important session. And how do we screen, and what are the current recommendations for the cancer treatment? About which all of us will be interested in knowing about it. And to present this session, we have our eminent speaker, Dr Sivasubramaniam, who is a consultant medical oncologist in Venkataeswara Hospital, Chennai, and he has the honor of having distinct two both way qualified for MD in radiation oncology as well as DM in medical oncology, especially in both the fields, and his knowledge and experiences are going to be really useful for us. And he has the honor of standing the first in the NEET medical oncology specialty, all India first rank. So it's a wonderful thing. He received Professor Ramchandra Endowment Gold Medal for getting university first. So he has been standing first in most of the occasions, and there's a wonderful thing from Dr. Sivasubramaniam, and he has the taste of serving the government also. He has served as a assistant professor in Madras Medical College, and he has got good teaching experience also, and he has many scientific publications, all the things and operations there. And we are looking forward to Dr. Sivasubramaniam to just give us a taste about what exactly screening methodology is and what are the recommendations currently available for the cancer treatment. Thank you.
Thank you very much, sir, for that introduction. So even though I stood first, I was given last to speak. So I don't waste your time much. I know everybody is tired. So I will make to the point so that you will get what is required for your day-to-day practice. So now just to know how many of you could not understand Tamil, please. Everybody can understand Tamil, so I can use very well Tamil in the Okay, thank you very much. So some of the screenings available for common cancers are breast cancer, which is the #1 cancer both in India as well as worldwide. And we have cervical cancer screening program, colon cancer, prostate cancer, lung. Lung is not for the general population, only for heavy smokers. That we have to know. So why do we screen? So whichever cancer takes long time to develop, which is called as late time. So the moment there is dysplasia, metaplasia and all those things, until the cancer develops, we have lot of time. So that time is available in many cancers. For example, breast cancer takes around 10 years to form. That's ERPR positive cancers. It takes 10 years for manifest as a symptom, that is lung. So colon cancer, it takes around 15 years from metaplasia and dysplasia. Even cervical cancer also takes 15 years from abnormal, that is CIN, cervical intraepithelial neoplasia, to manifest as frank cancer. So these precious time, that is 10 to 15 years, we use it as screening. So whenever there is primordial prevention, we do it by health education. Primary prevention is eliminating the risk factors, like we are eliminating smoking or we are eliminating by HPV vaccination, etc. So the point we are intervening is secondary prevention, that is screening. The patient is having the disease, but there is no symptom. So these things have been dealt in detail. That is 23% we have breast cancer worldwide, and worldwide cancer related mortality in women is 14%. So death rate has decreased by 24%, which is mainly due to mammogram screening. So these things have been dealt in the previous sections. I don't want to teach that. What are the components of breast screening? So self-breast examination, where the individual examines her own breast. Clinical breast examination, which is done by a health education or a health practitioner, healthcare practitioner. Risk assessment by mammogram, as well as and then screening. Mammogram in general means it is always X-ray mammogram. So, so if somebody uses the term mammogram, it always means that X-ray mammogram. Unless you tell it as it is sono mammogram or MR mammogram, it is always X-ray. And then what are the role of MR? So we will be doing one by one. So though this self-breast examination and clinical breast examination, they are did not show any decrease in mortality, but we do emphasize in our developing countries because everybody should be aware that there's something called breast cancer is available. If you go to rural areas, nobody knows that there is something called as breast cancer. They think it is normal. Only the moment they have some pain or discharge or ulcer, they come to the clinic. So, for developing countries, we have to emphasize on self-breast examination as well as clinical breast examination. So, you can put there are a lot of YouTube videos available how to go about this self-breast examination. So, I will just tell you what to do. So, every individual has menses from day 1 on an average to day 5. The moment on day 5 this menstrual cycle stops, so the hormone effect goes. So any lump can be palpated easily. So if you do before menstruating or on the day of menses, what happens? There could be small lumps palpable by your hand, which can lead on to unnecessary fear. So always do on day 6 from day 6 onwards. So we have to check for any new solid lump or any skin changes, nipple retraction or some erythema or redness, dimpling or some discharge from the nipple. Next is the clinical breast examination. So clinical breast examination is done by healthcare practitioner like you, general practitioner or any trained nurse or staff. So it has a sensitivity of around 60% and a specificity of 94%. So this is just like a clinical examination where we have given a long case for breast cancer in our final year surgery. So all the steps should be followed. Inspection, right from inspection, that is both the lump is, breast is equally positioned, or some nipple retraction is there, or on bending forward any retraction is there, or some abnormal changes over the skin like puny orange appearance. So everything should be dealt in detail. So this is a typical feature of a puny orange. Most of the patients come by this appearance only because we don't have the habit of screening mammogram. So how many of you done or advised our relatives to do a mammogram? May you know? Very good, congrats. So because many of them they don't do. So only the moment they see some cancer in their own family or somebody known to them suffer, they think about themselves that we have to do screening. But what happens is after 40 years they do once and leave it. So it is not like that. We have to do till 68 years at least. Again, the sensitivity of clinical breast examination is up to 54% and specificity is around 94%. So what does the guidelines say? So every woman should be started this examination from the age of 30 years onwards. So every year they can do by a healthcare practitioner. Self-breast examination is monthly. So whenever they have the menses over, they have to self-breast examination. They know what is the normal shape of their breast, what is the normal size, any abnormal changes, they should be knowing. Coming to the risk assessment, so always whatever the guidelines are told, it is for the general people, that is general population who don't have added risk. That means who are the people who are average risk means lifetime risk should be less than 15%. This can be calculated by using some calculators, or there are some genetic tools also where we can use this calculator to see what is the percentage that you can get cancer in your lifetime. So if it is less than 15 to 20%, that means you fall into general population. So always average risk means it applies to general population. So other things are, they should not have any personal history of atypical hyperplasia like ductal carcinoma institute, lobular carcinoma institute, because all these are included in this calculator. So whenever patient is having early menarche or late menopause or late childbirth, so or there can be late marriage, or there can be any previous history of atypical hyperplasia. All these things can have increased risk. So all those factors are included in calculating the algorithm. So for average risk, the guideline says that every 1 to 3 years. It is a very wide term. So some people they do yearly, some people they tell that once in 2 years is enough. But நம்ம மக்களுக்கு சொன்னா தெரியும். So once in a year சொன்னா at least once in 3 years வருவாங்க. So always for our practice we can keep it as once in a year mammogram. So they will think that போன பொங்கலுக்கு வருவாங்க அதோட விட்டு அடுத்த பொங்கலுக்கு. So they don't come at all. So always we have to tell for our situation. So all these things are Western guidelines. Once in 2 years means they will definitely do. So நம்ம practice க்கு பாத்தீங்கன்னா once in a year சொன்னாதான் at least once in 2 years or once in 3 years வருவாங்க. So even once in 2 years is also good actually. So what is the recommended age we have to start from 40 years onwards? US la வந்து 40 years சொல்றாங்க, UK la it from 50 years onwards. So for our patients it's better to tell that only from 40 years because we do come across lot of young patients with breast cancer. The youngest woman I came across is 15 years. She had a breast cancer. Probably it is due to BRCA, BRCA mutation. She is the youngest girl I saw. And youngest rectal cancer, it was 16 years boy. So for our scenario, we do come across lot of young breast cancers. So many people, around 30 to 40, so many breast cancers. So even though it is not recommended to do mammogram, at least they should do self breast examination. Any abnormal lump, they should come and meet a clinician. And also we have to be very careful whenever patient is pregnant. So every time pregnant ஆகும்போது என்ன பண்ணுவாங்க, இந்த மாதிரி பேஷண்டே வந்து எனக்கு லம்ப் மாதிரி தெரியுதுன்னு சொன்னா என்ன பண்ணுவாங்க, உடனே பிரெக்னன்சி எப்படி நார்மல் தாமான்னு சொல்லிடுவாங்க. There is terminology called pregnancy associated breast cancer. So pregnancy அப்பவும் breast cancer வரலாம். But that is the one which can be easily missed because we don't suspect this breast cancer during pregnancy and as well as during lactation. So lactation அப்ப நார்மலாவே எங்காச்சும் இருக்கும். So that time our mind don't think it is due to just lactation or normal pregnancy only. We label it as like that. So we should never miss any symptom or sign told by the patient. So always we have to suspect. So clinician arunda we should become a mentality of wife. We should suspect. That is our main aim. So that we can pick it up very early. So these are the risk factors who are having increased risk of breast cancer. Prior history of breast cancer. So they have an increased risk of the opposite breast cancer, opposite breast also. Or there is a Gale model where these things, early menopause, late menopause, or number of childbirth, that is age at which the child born, so late marriage, all those things are included in the Gale model. So those who have, by the algorithm, if they have more than 20% of chance of developing breast cancer, that is also included in increased risk. And patient who had radiotherapy in their childhood, for example, Hodgkin lymphoma, previously they gave only radiotherapy treatment. But nowadays they are trying to reduce the role of radiotherapy by giving chemotherapy only because long-term side effects like carcinoma, breast cancer, or patient can have lung cancer, patient have a thyroid cancer. Wherever the early the exposure, the more the risk. So if you are exposed to radiation at a young age, like for example 15 years, the patient will live for many years, up to 70 or 80. So there is a long time to develop secondary malignancies.
So is there any advantage of doing hysterectomy in post-menopausal women so that she will not get
Correct. No, uterine and ovarian.
Ovarian is the
in post-menopause, there is no evidence for doing prophylactic hysterectomy for all. But if they are found to be having this BRCA carriers, definitely we have to do. We should not wait up to menopause also. So menopause ஆகிறதுக்கு முன்னாடியே, the moment they complete their family, by the age of 40 years, they have to do TH, BSO.
BRCA gene positive means?
Positive, no, there is a role. Because hereditary cancer which we are discussing, 95% are random. That is sporadic. Sporadic, no, random or only just 5% are hereditary. So that can be easily found out. Hereditary means one is they may present in very young age, for example, as I mentioned, just 15 years, 20 years, abnormal age.
post-menopausal hysterectomy கிடையாது. very young age ல வந்தா பண்ண முடியாது.
What he's trying to say is at the young age la varudhan sir mostly hereditary.
We have to confirm, sir, why it. No, I'm not telling all young cancers are hereditary. So we have to test for the gene.
If it is positive, do you recommend hysterectomy for them?
Yeah, BRCA positive, that is role of prophylactic surgeries.
Angelina Jolie is
Bilateral mastectomy.
Everybody-
So my patient recently she underwent.
Late menopause, ரொம்ப நாள் bleeding இருந்தா கூட do you suggest hysterectomy for such people?
No,
So,
no.
but if they have till 58, 60.
No, it is not. Prophylactically, that is not recommended. If we may do it as a treatment for menorrhagia, but not for reducing cancer.
அப்போ கூட you don't. Such people are prone, no, in case they have a late
Yes, ma'am, but we don't.
stoppage of this thing.
But there is no such recommendation. We can use it as a treatment, of course, because patient may have a persistent menorrhagia, she may have anemia, and all those things, and we can use as a treatment, but not for reducing risk. So these are the risk calculators. I don't want to go into detail about that. These are available for free, so we can put some known factors in these calculators and know our risk, how much risk we have in our lifetime. But what I am going to tell is, so 1 out of 7 women, so here குழந்தைங்க பாத்தீங்கன்னா அவங்க லைஃப் டைம் ஃபுல்லா ஃபாலோ பண்ணீங்கன்னா 1 girl will develop breast cancer in her lifetime. So that is the scenario now. So 7 child you take from birth to death.
Risk calculators only for women than men கிடையாது.
Men is always exception.
Then it is not common, no? Is it common in men nowadays?
1 out of 10 breast cancer, 100.
Men out of
100 breast cancer in women, you see, 1 breast cancer in men. So 1:100 ratio. Very rare. This BRCA.
Breast cancer மாத்திரம் தானே அது?
One by one.
வேற எல்லாத்துக்கும் risk calculator sir. எல்லா cancers-க்கும்.
எல்லாத்துக்கும் இல்ல sir. எல்லாத்துக்கும் இல்ல. Breast is common, so always they do in detail this test. So this is the Gale model which I was mentioning. So this is the recommendation for high risk. That means patient is having on the more than 20% risk. So we have to start screening from the age of 25 year onwards. From 18 year onwards, she should have self breast examination or clinical breast examination. From 25 year onwards, they should be exposed to MRI because there is a theoretical risk of increasing radiation exposure in young women. Therefore, we should not expose her before the age of 30 years. So 30 வயசுக்கு முன்னாடி MRI தான் பண்ணணும். From 30 years அப்புறம் என்ன பண்ணுவோம்னா we alternate with X-ray and MRI. So every 6 months ஒரு 6 மாசம் இப்ப MRI பண்ணீங்கன்னா அடுத்த 6 மாசம் கழிச்சு X-ray பண்ணலாம். So that we can pick up in between interval malignancies. Because these are all high prone for cancers. Definitely that in the lifetime they will have this cancer. So that's why it is recommended for 6 months.
Mammogram which is better sir? X-ray mammogram or in the ultrasound mammogram?
No, ultrasound mammogram is not at all recommended sir actually. Only mammogram it is always X-ray, but many people they correlate. So radiologist they correlate with the ultrasound whether it is really like that. So that is what by correlating what happens, the accuracy is more. But if somebody is telling
X-ray தான்.
always, if they specifically mention solar mammogram or MR mammogram.
இல்ல but requisition pad it's given you want ultrasound mammogram or X-ray. I mean, it's asked for.
Sir, women above 40, you go for mammogram like that. If there are young breast, why we don't expose is because it will, first of all it will be very dense. The clarity is there. X-ray mammogram. அதனால அல்ட்ராசவுண்ட்ல சேஃபர் அப்ப தேவையில்லாத எக்ஸ்ரே எக்ஸ்போஷரும் தேவை for a younger breast. So above 40 we recommend mammogram. Below 40 we say ultrasound is sufficient. ஆனா அவர் சொன்ன மாதிரி mammogram அப்புறம் we do ultrasound correlation. எல்லா பேஷண்ட்டுமே breast screening பண்றவங்க we do a mammogram and then do ultrasound.
Doubtful then you do it.
Doubtful sir.
It is mandatory.
It's mandatory
sir.
ஆமா ரெண்டுமே mandatory.
நீங்க டிக் பண்றது first question was சிவா நம்ம டிக் பண்ணோம்னா எதை டிக் பண்ணோம் சார் எக்ஸ்ரே mammogram
used in parallel, you want ultrasound mammogram or X-ray
mammogram.
The use
It
in
is all-
mammogram, sir.
ரெண்டுமே
They will do
பண்ணிடுவாங்க.
both and said you don't mind.
Right mammogram. Right mammogram.
Cross check பண்ணிடுவாங்க sir. In case of discrepancy, they will do it complimentary ultrasound. Sono mammogram.
Because they don't have the X-ray specification for a mammogram, they do ultrasound. Because even some regular hospitals, ultrasound.
As per guidelines, mammogram means it is always X-ray. For better accuracy, they always correlate with ultrasound. But if it is a young woman, the best modality is MRI. So MRI, but not the sonomammogram. So sonomammogram is cheaper, MRI is costly. So if it is a poor patient, you can do a sonomammogram, ultrasound. We can finish it off by 1,000 rupees or 800 rupees. So if you tell MRI, it may charge 6,000. So for general practitioner, this will be fair enough, sonomammogram. But for young women, best modality is MRI rather than a sonomammogram.
Ultrasound breast is also.
So this is again a risk calculator. So how do we follow up the breast cancer survivors? So we should always be vigilant that the other breast also has chance of around up to 2% in the lifetime to develop cancer. So the moment we develop breast cancer, we should not leave the other breast. That also we screen every year. And annual gynecological examination, patient on tamoxifen can develop endometrial hyperplasia if patient tells that she is having bleeding PV or spotting PV. So always rule out endometrial cancer.
But all breast cancers you must give tamoxifen, is it?
Hormone positive, sir. We develop that, we dealing in the coming slides. ERPA, we always do immunohistochemistry. So the breast is divided into at least 4 types based on the biopsy report. So if it is hormone positive and HER2 negative, or ERPR positive as well as this HER2 positive, that is we call it as triple positive, hormone negative and HER2 enriched, we call it as HER2 enriched, or everything is negative, triple negative. So only for either ER is positive or PR is positive, we have to put her on hormones. Because I always insist my patients, there are 4 treatments. The thing that only surgery, chemo and radiation, that is the 3 treatment. But main thing is also hormone therapy. Many people they recur because they don't take the hormones properly, especially patients from. That is why we have to have them on close follow-up.
But how long do you give this tamoxifen?
Previously they used to give for 5 years, sir. Then again they changed to 7 years. Now the recommendation is 10 years, especially for stage 3 or stage 2. For stage 1 still we can use 5 years alone.
Depends on the case, I suppose, and the staging.
So my thing is I always tell 10 years because the moment you say 5 years and tell them 10 years, they don't accept. So if you tell shorter time, they will accept in the later time. So I always tell 10 years. We can follow up and we can, for stage 1 there is no necessity to give up to 10 years, only 5 years is fair enough. So this is the basic concept of mammogram, where we use a craniocaudal view and mediolateral view. So this is what I want to tell. So we could appreciate this glandular tissue and with this black area. So the more the black, as age advances, we get a lot of black, which is called fat tissue. So for young women, if at all we take this mammogram, so everything will be white. So if everything is white, how will we be able to put up a lump? So it is not possible. So if you more than 40 only, the black appears because of fat. Less than 40 means everything will be white. So we will not pick up the lump. So this is again a BIRAD score which everybody would have gone through in the mammogram reports. Category 1 means it is negative. Category 0 means they need further follow-up or previous reports they want. They cannot give any conclusive report. Category 1 means there is no abnormal thing, everything is negative. Category 2 means it's a benign. So again the chance is 0%. So this is called benign calcification, where calcified fibroadenoma or vascular calcification. So all those things are benign. Category 3 is probably benign. So the radiologist is not sure whether it is malignant or benign. So chance of malignancy is up to 2%. Again, these are the grey zone areas where the general practitioners or the oncologists miss. So because most of the time even the mammogram are done by any sonologist. So they may not give the appropriate. If we suspect a hard lump, clinically hard but BIRADs 3 still I suggest biopsy. because always we should believe ourselves. That report may be wrong, we don't know. We don't know the reliability of the report. So we should not miss the diagnosis. Every third or fourth patient I see is missed diagnosis because we do have sonologists who are reporting. There may be interpretation error. So always if you suspect clinically any postmenopausal woman, hard lump, think it as breast cancer unless otherwise proved by biopsy. So always a triple assessment, clinical, radiological and biopsy. So nowadays FNAC is not at all useful. Only core needle biopsy is suggested because we have to know accuracy, malignancy can be proved, FNAC can miss. So many places they miss by FNAC.
What biopsy?
What is the core needle?
Core needle.
Core needle is also.
Core means there is some small hole is there that will go and take some tissue and come by gun.
FNAC is also the same thing.
The FNAC is aspirations. Just cells will come. Cytology only will come. So here we have the tissue itself.
All the layers will be there.
Yes. So many times they do FNAC. FNAC is no more advised. So only core needle.
FNAB could have released a biopsy. FNAB, does it exist?
FNAB? No.
Fine needle aspirate.
Fine needle, no sir. FNAC only. This one, core needle is always, TrueCut is a trade name. It's a trade name. But core needle is a common name. So core needle, we have to.
For any lump in the, cervical node also.
No, usually less than 1.5 centimeter, we may not be able to do core needle biopsy. There we do FNAC. But whenever possible, core needle. Yes. Whenever big and accessible.
It's more painful also.
Not much, sir. Not much. Wearable only. Local anesthesia they give, but we have to identify those, sir. So that pain of missing diagnosis is better than giving pain now and diagnosing.
Pain of diagnosis is for your problem. For them, it's the pain.
But still, as a clinician.
Do it well.
Fine needle is ordinary, even 2 ml needle we put and we do.
The core needle it cannot be.
Core needle is a little bigger.
Wide bore.
Yes, little wide.
So category 4 is suspicious. Again, they were divided into 4A, 4B and 4C based upon the suspicion of malignancy. Again, it is broadly, category 4 means, now again they are divided into 4A, 2 to 10%, and 10 to 50 and 50 to 95%. So category 5, typical feature of this breast cancer is this one. So it is not circumscribed, it is irregular, number 1. Number 2, it is opaque. We could see this black, it is white. Number 2 is opaque. And this speculations. Speculations means there is irregular border. And we have a microcalcification. So these 3 are typical features of breast cancer. One is irregular. There is no well-defined thing. It is infiltrating, which is called as speculated margin, and opaque radiodiffusion. And number 3 is microcalcification, which is less than 0.5. And categories is already known, biopsy proven. So what is the recommendation is from 40 years onwards up to 75. As I already told, the age of, we can go from 50 years onwards. There are various guidelines. Up to 25% we can reduce mortality by do X-ray. This is the recommendation where we could see US people they recommend every 1 year, this one. But the upper one, UK they usually give for 2 to 3 years, but we have to modify to our practice. We always can remember as every year. So this is the screening mammogram. So all American people they tell that start from all these American obstetric and American surgeons and NCCN, American College of Radiologists, everybody tell that from the age of 40 years. We can also follow up because we do come across a lot of young breast cancers. And the UK people they tell from start from 50 years onwards. So what about this MRI? As I was telling, less than 30 years, better is MRI. But the problem is MRI is it will pick up everything. So if you do MRI for anyone, any combination definitely will come. So false positivity will be more. That is the problem. But there are certain indications where we could use MRI. For less than 30 years, we can use MRI breast. And known BRCA mutation, as I was, ideal is remove both the breast. Prophylactic breast mastectomy is the number 1. If patient refuses or the person refuses surgery, we can go by MRI screening method. And any first degree positive, one patient I came across recently, mother was 40 years, she had triple negative, tested for BRCA, she is positive. And her daughter, I told them to do BRCA, she is just 21 years. She is also found to be positive.
Yeah.
So I put her on stringent follow-up. MRI we did recently because she complained of some lump incidentally after knowing, but it is fibroadenoma only. But I gave a proper protocol because that scenario is just 5%. You have to remember that 95% it is random. That rare cases we need, that it requires a separate protocol. That won't be mentioned. We have to search for the literature. So on any previous history of radiation for any other disease. So they are comes under a high risk, and as we said, by using algorithm, if the chance of malignancy, breast cancer is more than 20%, again they come under high risk. So this is the summary of recommendation for breast cancer screening, clinical breast examination and self-breast examination from the age of 30 years every year. Self-breast examination monthly they have to do. Even though there is no evidence that it decreases mortality, for our developing countries definitely we should emphasize, because many people they don't know that something called breast cancer exists in the rural people, in the rural areas. So we have to emphasize that. And mammogram from the age of 40 years, best is above 50 years they have a best use, and MRI from the age of 30 years for high risk people. Okay. No, I give the slide, ma'am. You can take it home. The slide is for yours. So take home message is, mammogram is the only screening modality proven to have decreased mortality. Mammogram is always X-ray. All those recommendations are based on the X-ray mammogram. And clinical breast examination in countries that lack, many rural areas they don't have mammogram. So if you wait for a mammogram, we will miss. So self-breast examination, clinical breast examination, we should rely upon. And MRI only and ultrasound are only used as adjunct. And breast self-examination, breast cancer awareness, it is the motto of this NRHM. So next is cervical cancer. It is the third most common cancer. And gynecological cancer, it is number 1. Benefits of screening of cervical cancers detects around 10 years prior to before the cancer develops. So one rule is, if a woman undergoes this pap smear once in her lifetime, the chance of death by cervical cancer decreases by 50%. So one pap smear in her lifetime from the age of 21 to 65, chance of death, no, that much significant I am telling. Once is not enough, ma'am. Once in 3 years we have to do. Even if you undergo one time, 50% we can reduce the mortality. That much significant it is. So pap smear and the liquid-based cytology, both are more or less same concept only. Just mode of transport is different. For liquid we use a separate medium. For pap smear we make the smear and send. So this is the transformation zone. So this zone, previously this squamous columnar junction was this one. So as age increases or some other mutation, metaplasia, this gets retracted. This is the original area of transformation zone, and this is the transformation zone down. This interval is the place where the cancer develops. So original area and now the recent squamous columnar junction, the difference, that is the place where, that is called as transformation zone. So transformation zone may not be viewed during routine speculum examination. We have to put a spatula and do cytology and see. So this is how most of them will be trained, I think so, for doing how to do a pap smear. So this is how it is spread in the slide and seen. So we use a Bethesda staging for this, how to interpret. For low-grade squamous intraplasia, it comes under category 3. For high-grade squamous intraepithelial lesion, we have to intervene. For low-grade, we can wait and watch or do a HPV correlation. For high-grade, even for SIN2 and SIN3 are most of them clubbed together. So most of the time we do not distinguish between SIN2 and 3. So high-grade includes both SIN2 and 3. So those are the things we have to go for treatment. So this is the recommendation for cervical cancer screening. We have to start from the age of 21 years. From 21 to 30 years, we may not use this HPV testing because most of the people will have HPV positivity and it will be very transient. So most of the time after 30 years, that will vanish, this HPV positivity. So therefore, we don't recommend that HPV testing from 21 to 30. From 30 to 65, we have two options. Whether we can do only pap smear alone or we can club pap smear and HPV. So if we club together, we can do once in 3 years. So if you do only pap smear, once in 3 years we have to do.
After 65, after 65,
65 it is not a mandatory, ma'am. If our life expectancy is more. So all the screening program, what happens is, based on the average life expectancy is around 71 years or 72 years, based on the place where we live. So above 65 years, it is optional most of the time. Even the breast cancer from 68, it is optional. So if you are very fit and if you think that we will be living for up to 80 or 90, so definitely we can go ahead. Because there is a dilemma. If patient is very bedridden at the age of 70 years, he has so many comorbidities. Even if you pick cervical cancer, there is no point in picking up by screening. So that
it
can
is
be
not mandatory after 65.
all the guidelines tell up to this only. Because why? Because average life expectancy of a person is around 70 to 75. So even if you pick up by 68 years, our life expectancy may be 71. So, but it can be individualized. I'm not telling it is not necessary. It can be individualized. It's up to us whether to go or not.
Once you
65 and
live
above.
up to 70 years, that time you feel you should do all these things.
Definitely. That time only all the fears comes.
Are my 65 ke mele screening mammogram once in how many years after?
Screening mammogram. So it is 1 to 3 years, ma'am. That is what the US tells that.
After 65, that
Yeah,
is.
yeah.
Inge matru it is not mandatory.
Which one, ma'am?
PAP.
PAP mandatory, but it can be used if patient is life expectancy is quite good. The woman is fit
The
enough.
woman is fit
Just
without
10
any
years.
comorbidities.
Yes, ma'am. So suppose she is bedridden, there is no point in doing screening.
Okay.
So if usually they give a cutoff of 10 years. So another 10 years, if we think that she may live, definitely we can continue screening. Usually the dictum is 10 years. So this is, everybody would have known that sir was telling from 9 to 14 years we have to vaccinate.
So Gadas illa nariya
Gadas
variants.
in nine-
You got different
nine-
types, no?
nano-
With the pre-filled syringe,
Nanovalent.
without the pre-filled syringe, ella varde. Which would you recommend actually? 5 types are coming. 50.
So usually recommend is nanovalent, 9 strains it should
9
cover.
strains. Okay.
So it is not easily available. Only quadrivalent is very
Quadrivalent,
common.
that's 5 type.
Four.
Four.
Six
Actually,
are-
வந்து ரெண்டு variety வருது without the pre-filled and with pre-filled the ரெண்டு வருது.
That doesn't, mostly it comes in the liquid form.
Liquid form.
0,
Now
1,
இப்போ
6.
புதுசா pre-filled syringe ஓட வருது.
But more or less same only.
Price is more. Patients once they take that, they don't want to go for the other.
Just like Covishield and this thing. They used to get adopted for that. But preferred is nanovalent because it covers the other uncommon strains also. As well as this anal.
Cervarix is how many variants does it have? Gadas illa quadrivalent. Cervarix
அது ரெண்டு தான் 16 and 18. Malignants only. இது வந்து வாட்டையும் கவர் பண்ணிடும். Benign lesion as well as people. It is recommended for this homosexuals also. Those who are undergoing anal sexual intercourse, that also can be covered. Males also can get vaccinated by this nanovalent.
males என்ன age ல vaccinate பண்றது?
It is அதே மாதிரி தான் the
9 to
9 to 26 the main age group.
Right.
So again, colorectal cancer, there are various polyps which we can come across. That is hyperplastic polyp. The serrated adenoma has a more chance for malignancy. So these are the various screening methods used for colorectal cancer. The number one is colonoscopy. Next is fecal immunochemical test, and the next one is this one DNA analysis. Next one is sigmoidoscopy. Then fecal occult blood test and the FIT DNA. So all those things have been tried, but recommended is colonoscopy only. So from 50 years onwards, once in 10 years is enough. If you go by sigmoidoscopy, we have to do once in 5 years. So this fecal immunochemical test and fecal occult blood test, we have 3-4 types, but they are not sensitive for small polyps. Less than 5 mm, they may not pick up this fecal occult blood. So recommended is only colonoscopy from 50 years onwards.
No, but it's a horrible procedure.
So again I told there is a lot of time, around 15 years it takes for a lesion to become from polyp and metaplasia, dysplasia, carcinoma and invasive cancer. It takes around 15 years. So that is why if you do colonoscopy 10 years back, next 10 years we can be safe. Unless there is some other adenoma, previous multiple adenomas, more than 100 or 10 to 100, those things we have to follow.
Colonic cancers are more common in non-vegetarians, is the fact.
Yes, yes.
But I do come across vegetarians also getting, they may have chance, but thing is, the more the processing happens, the more this carcinogen happens. So if you bake this barbecuation, all those things are very fried items. So the more the fry, you have carcinogen. So that's the fact. But even vegetarians, they do get. But colorectal generally we advise with fibers. Because the concept is, if you eat a fiber, fruits, we can test it ourselves. Within 4 hours, our evacuation will happen. But if you use a non-veg, it will happen for 2 to 3 days. We may have constipation. So the amount of time where the products, waste products stay in our body, the more the exposure and the more the metaplasia contact with the epithelium. So if you use fibers, so all the waste products, carcinogens, that will be come out of our faces. So the contact period can be minimized if you take more fibers. So that is the main thing.
Adhe madri manjal, does it have a role? Taking lot of manjal in your
Correct.
food?
It is just an antioxidant. So anything which has an antioxidant property, turmeric is also antioxidant. We do have a lot of supplements also, which you would have come across, many people would have, reps would have come across. So anything which has antioxidant property like vitamin A, vitamin C, vitamin E, so anything or fruits rich in these antioxidants, they will help us by eliminating this free oxygen radicals, scavengers. They act as this abnormal oxygen species can be removed by this antioxidant. So because those are the things which mutate the DNA. So those things can be removed by this antioxidant.
Our diet has got lot of junk.
So people who have this previous history of adenoma or colorectal cancer or inflammatory disease, they have a higher chance. So there is no stringent colonoscopy protocol for. So this is the recommendation for FIT immunochemical test. Once in 1 to 3 years we can recommend, and fecal occult test, that is guaiac based test, every year we can do, and we can also assess for the stool DNA test. Every 3 years it can be done. But recommendation is only colonoscopy. From 50 years onwards, once in 10 years, unless it is normal. If there is something abnormal, there is recommendation before.
CT colonography is as good as colonoscopy, yeah?
No, only patient refuses or patient is a high risk patient. Suppose recently I came across one patient, he is having ejection fraction only 23%. So putting anything inside him is high risk, non-table risk. So that scenario we can use this. But it is always used as adjunct, but not the first line. Always colonoscopy, because one thing is we can take biopsy. But if something is seen in CT colonogram, we cannot do biopsy. It is more both investigative as well as to take the biopsy helps. Sometimes if there is polyp, it is a curative also. So this is the recommendation for if after a colonoscopy, if colonoscopy is normal, or only hyperplastic polyps up to 20, once in 10 years is enough to do next colonoscopy. Or if there is 1 to 2 adenomas, that is less than 1 centimeter, after 7 years we can repeat a colonoscopy. Or if there is a serrated polyp less than 10 millimeter, 5 to 10. So what we have to know that adenomas are always harmful, especially the more the number. So more than centimeter is harmful, adenomas are harmful, especially sessile ones, as well as the numbers. So the more the number. For example, FAP, they have more than 100 polyps, familial adenomatous polyposis. So these things we have to see. And also one particular type called tubulovillous adenoma. So those things are harmful. So coming to prostate cancer, there is a controversy whether really prostate cancer should be screened, because it's a So if you want to, if you have an option that we should choose one cancer where we could suffer from, we could very well choose prostate cancer because it is harmless. Only as it advances, it is harmful. Above 80, if you screen, around 80% will have prostate cancer, above 80 years. So that much common it is, but it is a very slow growing. Even there is the option of surveillance, even knowing that it is cancer, we need not jump to treatment, radiotherapy or surgery. For example, if patient is having a Gleason score of just 6, the grading of the tumor is only 6, PSA is just 5, they fall into low risk. So for them there is the option of surveillance. So there is no role of surgery, no role of radiation. We can just observe, nothing will happen. If there is a high grade, or if the PSA is very high, more than 10, then we can intervene. So because it's a very good disease. That is why what happens, this screening, what happens, it picks up the good variety. So it won't pick up the bad varieties. There are, if grading is high, PSA may not be secreted. So for example, Gleason score is 9 or 10, PSA won't be elevated. That time it will miss, but it will pick up all the good varieties. So that is called as lead time bias. That is why by screening what happens, we are picking up the good disease that may not be turned into actual survival benefit. Because we are picking up the good disease. Even if you don't do anything, they will be happy. Patient will be happy. So there is some controversies in doing this screening for PSA. One trial showed benefit, the other showed there is no survival advantage. Why? Because it picks up the good variety rather than the bad variety. Whereas in breast cancer, it picks up everything. Any lump, even the good breast cancer it pick up, bad breast cancer it pick up, but it does not distinguish between. So PSA, we have to remember, it is prostate specific and not prostate cancer specific. So anything abnormal in prostate can elevate, but not necessarily due to cancer. So this is the thing, there is a 75% reduction in advanced stage of presentation by doing prostate cancer screening. Compared to UK, screening is only performed in 10% in UK. Why? Because there is a difference. One trial was showing that there is 20% reduction in mortality. So the other one, PLCO trial, did not show any difference. Because of this controversy, there is still debate going on whether prostate to be screened or not. So traditionally, more than 4 nanogram per ml PSA, we have to suspect prostate cancer. Especially the density, prostate density means total volume, PSA level by prostate volume. The ratio is more than 0.15, there can be a chance of cancer. Or if last year if you see 4, this year if you see 5 PSA, so it is more than 0.75. So velocity is more important rather than that one particular value. So last year if it is 4, now this is 5. So it is more than 0.75. There can be a chance of prostate cancer. And the percentage free PSA and total PSA, there are 2 PSAs. The more the free PSA, it is good. In cancer patients, combined PSA will be high rather than the free PSA. That also we have to see the ratio. So what we can do is from 45 to 50 years, we can obtain a PSA value and see what it is. If it is more than 1, again we have to retest. So ideal age of recommendation is from 50 years onwards. Every year it can be tested. If there is a hard prostate or PSA more than 3, so we can go for biopsy or MRI. So conclude, PSA screening does yield survival benefit because one trial was showing a survival benefit. PSA screening picks up cancers 5 to 7 years prior to symptomatic disease. And PSA screening may represent overdiagnosis in 25% of people. So carcinoma lump, this is recommended for a heavy smokers, not for general population. Those who have smoked for 30 pack years. If you have smoked for 30 years, 1 pack per day is called as 30 pack years. So from 55 to 80 years, they have to be screened. And even if they leave smoking, up to next 15 years, they still have the chance of developing this lung cancer. So that does not mean that we should not start, but still there is next 15 years also they have risk. So low dose CT annually, that is the recommended. Rather than chest X-ray is not at all useful in screening for lung cancer. Only low dose CT, there is a 20% reduction in mortality. So then I will just briefly touching what are the bird's eye view of how to approach each cancer. So this thing I want to just stress upon, where we should not do biopsy. We know that everywhere we do biopsy and we send for biopsy, and after confirming only we do the definitive treatment. Suppose if we suspect a complex adnexal mass, so it is just a fluid filled balloon, so we should not pour, otherwise it will fill in the abdominal cavity. Already if it has spread stage 3 peritoneal metastasis, then we can definitely do, because already it has spread. But stage 1, sometimes very rarely we come across stage 1 cancer also. That time we should not put a needle. Testicular tumor, if we suspect any intratesticular mass, that itself is an indication for orchidectomy. That may be anything, we don't know. Any intratesticular solid mass is itself a indication for high inguinal orchidectomy. So there is, every term is important, not a low inguinal, high inguinal, and it is good through inguinal approach, not transscrotal. So if you put a needle through scrotum, the lymphatic drainage of scrotum is inguinal region, so it will upstage. So it will become a non-vaginal node and it will become metastatic rather than a stage 1 or 2. Then suppose if you see incidentally we may come across some kidney mass. So that time also we need not go for, there is some criteria for grading of this tumor also. It may be malignant or benign. That time also we can straight away go for nephrectomy. Many people come with radical nephrectomy, they would not have undergone any biopsy. Directly we can go. Suppose if it is already stage 4, we have to start treatment, then we can do biopsy, confirm and then go. But if it is confined to kidney, we need not. And even for hepatocellular cancer, if there is a background of cirrhosis, there is some, we usually use a triple phase CT. So arterial enhancement, venous washout and capsular enhancement. So this typical feature should be there in the background of cirrhosis. So if patient is not having cirrhosis, or if there is no typical feature, patient is having cirrhosis, this typical feature is not seen, or typical feature is seen, cirrhosis is not seen. Either way, we can do biopsy to confirm. Otherwise, we can diagnose only by triple phase CT only. No need of biopsy in hepatocellular cancer. One time glaucoma, we don't do biopsy because that is a place for respiratory control. So nobody touches that. Directly we go for radiotherapy. So for anything radiation, we don't go before biopsy proof. But this is an exception. And any this jaundice where we have to go with this procedure, we need not confirm by biopsy. If radiological picture is showing malignancy, we can go ahead with biopsy. Definitive surgery. So for breast cancer, always as I told, core needle biopsy, it is not FNAC. So FNAC, one, we can miss the diagnosis, and number 2, we could not see this ER, head to new, everything. So nowadays, even for small tumor like 3 cm tumor, we are suggested to give chemotherapy first, because if by chemotherapy the tumor disappears after 6 cycles, patient have a good prognosis. So especially this head to enriched or triple negative, anything more than 2 cm, nowadays the recommendation is give chemotherapy first rather than doing surgery first, because we could appreciate whether it is chemosensitive by giving chemotherapy first. Because if you remove the tumor, we don't know whether the chemotherapy is resistant or sensitive. That we can visualize. Many people, if we give chemotherapy after surgery, if you see post-op specimen, there is no tumor at all. So those patients will have a very good prognosis. So that is why first itself we have to do ER, head to new and K67. So from stage 3 onwards, we can either do PET CT whole body or we can use CT chest and abdomen and bone scan. So MRI test, if at all we are planning for breast conservative surgery, it may be helping to plan for surgery. So other things are routine. So these are the various surgeries. Nowadays, we are trying to reduce the amount of surgery by doing breast conservative surgery and doing sentinel lymph node biopsy. Sentinel node is the first node where the tumor spreads. So if that node itself is negative, there is no point in taking out every node. That is the concept. So on table they inject a dye or they inject a radioactive material. They look for the uptake in the node. So they test at least 3 nodes. So on table, if pathologist says there is no tumor, he will leave, only he will remove the breast lump and leave. If there is some positivity or 2 or more nodes are positive, we have to remove the level 1, level 2. Because many patients you would have seen in the clinic, after treatment they will come like a lymph lymphatic structure then.
Correct.
So once if it is developed, we cannot cure that. So that is why we are trying to avoid by minimizing the treatment, at the same time not compromising the outcome. So in oncology, first preference is cure only, next only side effects. So chemotherapy, most of this we cannot escape from chemotherapy, breast cancer, because at least 1 centimeter that is the indication. Except for the hormone positive, very good type, even for 1 to 3 nodes we avoid chemotherapy. So but most of the times we have come across a young female or triple negative, node positive, HER2 enriched, or grade 3 high grade lymphovascular space invasion, peritoneal invasion. So anyone will be coming into the picture. So therefore most of them come with chemotherapy. So these are the indications for radiotherapy for T3 tumors, that is more than 5 centimeter tumor, any node positive. Previously up to 4 nodes only they were included. Even 1 node positive we have to give. Margin positive, that is the resected margin, if it is positive, ideally we have to re-resect. So they should be undergoing second surgery to remove the negative positive margin. And then T2, some T2 with high risk features we can consider. And as we were discussing, at least 10 years, the thing is, before menopause we have to use tamoxifen. After menopause the source is peripheral fat, that is why we use letrozole. We cannot use. One woman I came across, somebody has, I don't want to mention the name, somebody prescribed letrozole for a premenopausal woman. She recurred. What happens? This aromatase inhibitor that will have a negative feedback mechanism, thereby that will produce more estrogen. So if you give by mistake this letrozole to a premenopausal woman, she recurred actually. Otherwise everything was fine, there is no high risk patient. We rarely come across this ERPA positive, recurring is quite rare. But this one I noticed, she was taking letrozole. She is only 34 years. I don't know why they prescribed it. So then coming to lung cancer. So lung cancer, what I want to stress is how to take a biopsy. So again, this one peripherally located and medial we come across, outer 2/3 and inner 1/3. So we could see that by needle we can put this one. We can put a needle through this posterior aspect and take biopsy. So peripherally located tumor it is easy to take biopsy. Whereas the central tumor, so if you put a needle, what happens? This pleura and everything ruptures, patient will end up with pneumothorax. So central tumors we have to go by the bronchoscopy. The outer tumors we have to put a needle. But preferred method is core-needle biopsy because we will get adequate tissue. So we have to do immunohistochemistry, we have to do this mutation panel, especially for stage 4. So for preferred is peripherally inserted needle. So up to stage 3A, we have to do surgery, but 90% they present with stage 4 lung cancer. Up to 90% only stage 4. Some around 10% they present with this advanced stage 3A or 3B, where we can give chemoradiation. Otherwise, this operable tumor that is stage 1 or 2, it is very rare. This is 5% only they present.
But what has been the longest period when a patient has survived after lung cancer?
That is for 90% they present with stage 4. Most of them they succumb to the disease.
So within 1 year?
Not 1 year. Previously it was so, only chemotherapy. Nowadays we test for this mutation panel. That is why we need to take adequate tissue. So every time we stress lung cancer, take multiple course. So we have to do this mutation, especially this EGFR mutation in female. Nowadays female lung cancer is also quite high. Many females they do have lung cancer without any risk factors, smoking or tobacco habits. There is a EGFR mutation can be there. Up to 50% that can be mutated. So if you give just the tablet alone, that is enough. No need to go for chemotherapy for that mutation. So that is why we have to test. So with this, around the life expectancy has increased to 3 years on an average, even for stage 4. So this is the cervical cancer. Again, the point I want to stress is early disease less than 4 centimeter. If para is free, they can undergo surgery, radical hysterectomy and with the lymph node dissection. And we cannot leave after surgery. We have to see the post-op report, whether there is indication for adjuvant treatment. especially more than 4 centimeter, or sometimes margin positive, para-positive, external extension, all those things will require adjuvant chemoradiation. Most of the people, they present with locally advanced, either more than 4 centimeter, para involved, and we have to end up with chemoradiation only. For head and neck cancer, what I would tell is for oral cancers, oral cavity, tongue, buccal mucosa, that is more common, that cannot be cured without surgery. What amount of radiation you give, they won't cure. So if patient is not suitable for surgery, then only we give radiotherapy. For tongue and buccal cancers, because they keep the pond there only. So tongue cancer, buccal cancer are very common. But this throat cancer, larynx or tonsil, posterior pharyngeal wall, first modality is chemoradiation only. We can cure with chemoradiation only. No need of surgery, no need to take voice parts. Patient can have this organ conservation. So other things can be cured with radiation. Even after radiotherapy, if there is some diseases remaining, then we can set for surgery. But tongue and oral cavity never cured with radiotherapy, very, very rare. So this is the technique we use, radiotherapy. Madam would have dealt in detail. So next coming the ovarian cancer. So again a point I want to stress is if it is confined to ovary, don't go for biopsy. So rather what we do is we do a frozen section. Take the patient per table, tell her that it can be cancer, and tell her all the surgery which you are going to take a consent for them. On table, the pathologist tell within half an hour, that is frozen section. Then we can complete the surgery by doing a lymph node sampling. Otherwise it will be just a simple oophorectomy. If it is a cancer, we have to remove the uterus also, opposite ovary also. Because chance of malignancy arising is around 10%, that is why we have to remove all the organs. So this is a typical complex adnexal mass. There we could see some solid material inside this. So if it is only uniform, that is called fluid, it is a cystic mass, most likely benign. If there is some heterogeneity or thick septation, more than 3 mm, we have to suspect ovarian cancer. Uterus, any rule is any postmenopausal women with endometrial thickness more than 5 mm, rule of cancer. So lymphoma, we have to do excision biopsy always. So whichever node is peripherally located, like neck node, axillary node, the least preferred node is inguinal node, because that can be reactive most of the time. So again, colon cancer, primary modality is surgery only. After surgery, from stage 3 onwards, definitely we have to give chemotherapy. For stage 2, we have to see the risk factors. Patient had any perforation, patient had any obstruction, or grade is high. So all those things can be given for chemotherapy from stage 2. For stage 1, there is no role of chemotherapy. So only in rectal cancer we give radiotherapy. The concept is the organ should be fixed organ. So colon will be moving. One day it will be here, one day it will be there, small bowel. So whichever organ is fixed, that is retroperitoneal organ, we can give chemotherapy. Rectum is a retroperitoneal, it is a fixed set. Therefore we can give radiotherapy because the target won't move. This prostate, what I would like to stress is, we have to go for a MRI, pelvis first, and if there is any abnormal uptake or any mass is in, we can go for biopsy. One specific PET CT which is specific for prostate is PSMA PET. So that is used only for, there is PSA based this PET CT. Rather than a PET CT, we can go for PSMA PET CT. So again, as I was mentioning, immediately we need not jump into treatment the moment prostate cancer is diagnosed. We have to see whether it is low risk, intermediate, is high risk. Risk is based upon the expected surveillance. Patient is going to live only for next 2 years. There is no point in doing surgery for him. So we can do surveillance. In localized disease, either we can go for radical radiotherapy or radical prostatectomy. Both are equal. There is no, but one thing is, radiation is always organ conservation. Many people they refuse. The moment we put bag here, they will refuse. So if you explain that. For advanced stage, just we remove the testis. Testis is a one-time removal. We do have medicines like GnRH that will block the testosterone. So if you remove the testis, it's a one-time event. It is cost effective because only one time they are going to spend, whereas these medicines every month they have to spend. But both are small surgery, that is orchidectomy, we can very well offer medical treatment. So this is how patient is positioned for radiotherapy. Again, I was telling this hepatocellular, this is what I want to tell. This is arterial enhancement, where we could see this contrast uptake, and the venous it is washed out, that is, this uptake is reduced, and there is capsular enhancement. So this is a typical feature of hepatocellular cancer with a background of cirrhosis. So treatment for HCC is, we have to see whether patient is having this comorbidity, that is cirrhosis. If there is liver is already not functioning, we can go for transplant straight away. Or if liver is functioning well, we can either go for local surgery, especially if it is less than 5 cm. Radiofrequency is a non-surgical method. And again, radiofrequency ablation or radiotherapy we can use. And one more method we use is transarterial chemoembolization, where we inject, go to this artery and inject this. Because normally we get a blood supply from this portal vein. Now it is reversed in this hepatic tumor, where we main blood supply to the hepatic artery. For advanced disease, only chemotherapy. So I hope everybody is tired. So I just want to brush across because it's a very vast topic. The moment I heard the topic, 6 years ago, they want to finish in 45 minutes. Treatment of cancers. So very, I was surprised. But thing is, what general practice we do come across only few things. So I want to stress those things, especially avoiding biopsying testicular tumors or ovary, because it's upstages the disease, prognosis also varies. So that is why. I'm happy to invite thoughts and comments and everything can be questioned.
Gallbladder polyps or any polyp anywhere in the body, what is the significance as to how that could progress into any malignancy or anything?
Polyp in the colon or in
polyp in the gallbladder, if it is there without any symptom, just identified in routine ultrasound.
We can suggest this surgery, otherwise we can observe. Only symptomatic we have to address. I think sir could put better thoughts because...
My question is, colonic polyp, whatever it is, take it off.
No, gallbladder.
No,
Gallbladder polyp, anything more than 1 centimeter, incidence of malignancy is high, even if not at that point, at some point, yes. One. Second thing is, if you see it in a younger patient, life expectancy is more, so why take that chance? Otherwise, you'll have to keep the patient on serial follow-up. Not an emergency surgery. Whenever the patient is okay, or if you see any progress in between, progress in size, please take it off.
But you are removing the whole gallbladder.
That's okay, because there is gallbladder malignancies have very poor outcome. Very, very, very poor outcome.
When gallstones, they say immediately remove it off. Is it a fact?
That is with a pinch of salt.
Yes.
Okay. Large stones, multiple stones, yes, please take it off.
Mobile stone.
Okay. Mobile stones, patient is symptomatic, please take it off.
Otherwise, not.
Problem with gallbladder polyps is, ma'am, there is no way of identifying if it is benign or malignant. You can never find out unless you subject the polyp to a histological examination. Okay. For that reason, if you see a polyp, young age group, please take it off. Size doesn't matter. More than 1 centimeter is something to be scared about, but even if it's 4 or 5 millimeter, young patient, take it off. Not an emergency, but please keep the patient informed. Take it off before it's too late.
Why does the polyp come suddenly?
What is the reason
Just
for
an
the polyp?
operation and growth, sir. That's it. No reason per se.
It is just a growth.
Just a growth, unequal growth. That's it.
Anything specific for diabetics, sir?
Diabetics in malignancy.
No, sir. Diabetes in polyps, with polyps.
Diabetics with polyps. The indication of prophylactic cholecystectomies for diabetics doesn't exist anymore. Polyp or whatever reason, even for gallstones, polyps, yes, the general dictum still stays good for them. But diabetics with stones or diabetics with cholecystitis, prophylactic cholecystectomies is not indicated anymore.
Thank you.
Thank you.
Yeah, thank you.
Thank you, Dr. Sivasubramaniam. It was a wonderful presentation. Keeping the last session going is very difficult. He did it very well now. Because a lot of the topics he discussed is really important to general practitioners. The interpretation of PSA, the sono ultragram, the mammogram and X-ray mammogram, all these things are very significant things because these are the areas where we get a lot of confusion about it. So he enlightened about it, he did it elaborately on each and every one. in spite of the fact that it is the last session. And that's a wonderful thing, Dr. Sivasubramaniam, and thank you so much. And as a mark of our gratitude and appreciation from the Independent Medical Practice Association, we are just presenting the memento to Dr. Sivasubramaniam. Thank you.
And they have done radical mastectomy and that's very but no, is it the correct way? But you said we have to give this is for sensitization of chemotherapy prior.
Now recommendation is to enrich. We are triple enrich. More than 2 centimeters. First is only taken. So now the protocol has changed.
They have done mastectomy.
Most of the centers they do, but still, even chemo has old protocols has become problem.
Chemo she refused. No, didn't have.
Here